diabetes. Very important part of management in our diabetic patients. High blood lipid levels are considered as a major cardiovascular risk factor, and particularly high LDL cholesterol. As you all very well know that diabetics are at 3 to 5 times increased risk of having cardiovascular disease. So we need to target these risk factors very specifically in our diabetic patients. All patients with type 2 diabetes and established cardiovascular disease should start treatment with a statin. That is secondary prevention. But those who do not have cardiovascular disease should also be offered treatment as a primary prevention. So regarding this, a lipid profile should be done at the time of diagnosis. A lipid profile should be done in a fasting state, which includes total cholesterol, LDL cholesterol, high HDL cholesterol, and triglycerides. These are the 4 important components of the lipid profile that you should order in your patient initially at the time of diagnosis. And then once you have done it, you have got the results back, and it shows that the levels are raised, then obviously the first step in the management of dyslipidemia is lifestyle modification, especially targeting at weight reduction in overweight or obese people. Because if they lose the weight, their cholesterol levels and particularly their triglyceride levels come down. In a normal weight person, exercise does not lead to reduction in cholesterol or triglyceride level. Modification of diet is the important part of the management as well, in addition to weight reduction. And that will have an impact on both patients who are obese as well as those who are non-obese. They will have a reduction in their lipid levels with the modification in the diet, taking a low cholesterol, low fat diet. Now, once these things have been started, the weight reduction as well as the dietary restrictions. The third thing is the statins. Statins are an important part of treatment in patients with diabetes. All patients with type 2 diabetes over the age of 40 should be started on a statin. Or those who are below, if they have an additional cardiovascular risk factors. And you need to up titrate to reach an LDL cholesterol of less than 70 once you start them on a statin. Despite any level of baseline LDL, unless a very clear risk is identified to withhold the therapy, that is for all patients above 40. For less than 40, if there is an additional risk factor other than diabetes. So basically, we are talking about primary prevention first. All patients with type 2 diabetes and without established cardiovascular disease should start treatment with a statin. Primary prevention, who are greater than 40 years old and whose LDL cholesterol is greater than 100. So, and for these patients, statins, and then there are moderate intensity statins and high intensity statins. You need to start moderate intensity statins for patients for primary prevention. Non-statin lipid-lowering agents are usually not required. It's only considered if the patient is not tolerating statin or a particular LDL goal is not achieved on a statin alone. Addition of a non-statin lipid-lowering agent can be considered. But a statin is the first-line treatment for lipid lowering in patients with diabetes. The target LDL cholesterol is to be lowered by 50% of the baseline or less than 100. In fact, in patients with atherosclerotic cardiovascular disease risk factor, the target should be less than 70. We're not talking about patients with established cardiovascular disease. In that, the target may be even lower. One more thing that we see is the hypertriglyceridemia in our patients with diabetes. And even the controlling the diabetes leads to a reduction in the triglyceride levels. So that you should be aware of, that by just controlling the diabetes, the triglyceride level will come down. But if the triglycerides are high, more than 150 but less than 500, despite strict lifestyle modification, glycemic control, and statins, then you may start statins for this as well. But if the levels are between 150 500, if the level is more than 500, then you need to start fibrates. If triglyceride is greater than 500 or 1000 or above, despite lifestyle and improved glycemic control, should start a fibrate. And the purpose is to basically to prevent pancreatitis, but also it reduces the chances of cardiovascular disease to some extent. But this evidence is not that strong for cardiovascular disease. The main purpose here is to decrease the chances of acute pancreatitis. Now, most of our patients and some of our physicians do the same thing, that once the cholesterol levels or the triglyceride levels are in the range, they tend to stop the statin therapy. That's totally wrong. We need to tell our patients that we started on a statin and you're going to remain on a statin long term or lifelong, as long as there is no severe side effects to it. So when a healthcare provider considers that the patient needs a statin, therapy should be maintained lifelong. So that is something very important to know, and I think to practice as well in your clinics. So I think with this, I would like to finish my presentation, and that's my last slide. So with this, I will pass on to Ali Asghar for.
Thank you very much, Professor Najmul Islam, for your elaborate discussion on the guidelines on diabetes, dyslipidemia, and hypertension. We definitely have questions. All are you can post it in the chat box, and we'll be taking these questions after we are finished with both the talks. Now we have Professor Dr. Saeed Maher. As I already introduced him, he's Professor of Endocrinology at National Institute of Cardiovascular Diseases, as well as Aga Khan University Hospital. He's the past president of Pakistan Endocrine Society and the executive member of Pakistan Endocrine Society. Professor Dr. Saeed Maher would be presenting part 4 of the guidelines on diabetes mellitus and cardiometabolic syndrome. This is the last part that we will be presenting today. Professor Saeed Maher, over to you, sir. Yes, sir, perfect. It's absolutely visible on our screens. You can start, sir.
Bismillah Rahman Rahim. Thank you, Ali, and the Pakistan Endocrine Society for inviting me to share actually the role of the guidelines we have made with the Pakistan Endocrine Society. And as Professor Najmul Islam has already shown to you, that I was also one of the authors for this guidelines, and we have already this is the second or updated version of these guidelines. We have actually published these guidelines few years back, and this is the updated version with the addition of new updates in these guidelines. So I will be moving forward where Professor Najmul Islam has left. So these guidelines, for my colleagues who are listening to this, that they have been published as a special supplement in November 2020. So if anyone who want a hard copy of it can have the November 2020 publication of JPMA, and they have got the whole guidelines at one place. Now, I will be talking about actually the low dose, first the low dose aspirin, that whether the low dose aspirin should be given to everybody or not. So the first thing is that the low dose aspirin therapy is an option in people with diabetes mellitus who has got increased cardiovascular risk. That's actually the primary prevention. Now, what are the people who has got in which we can consider as a primary prevention? That someone who has got a family history of cardiovascular disease, someone has hypertension, history of smoking, dyslipidemia, albuminuria, and age more than 50 years. Now, in this group, yes, you can consider after a proper history that there is no contraindication, you can give aspirin to these patients. But aspirin should be given to all patients with established cardiovascular disease as a primary prevention. For example, the post-CABG or post-MI or post-PCI. It may not be recommended in people with younger than 50 years of age with no additional cardiovascular risk factors. Those the important question sometimes asked by the junior colleagues, that someone who is not tolerating actually the aspirin, what should we do? Now, someone who is not actually tolerating the aspirin, then definitely the other option with us is actually the clopidogrel should be given as an alternate to the aspirin to these patients. What is the dose? Usually, what we have seen that the usual prescribed dose of aspirin is around 75 milligrams per day, but the dose varies from 75 to 162 milligram per day for both primary and secondary prevention where it is indicated. You have seen that there are certain prescriptions in which there is a dual antiplatelet therapy. That means aspirin with clopidogrel, which is usually not indicated for the primary prevention, but for the secondary prevention, as I said earlier, after the first year of the PCI, yes, these patients are given the dual therapy of aspirin plus clopidogrel. Now, patients who has got the retinopathy, they should have a dilated eye exam by an ophthalmologist. This is something which we say to all our patients, that whether you have got any problem with your eyes, you don't have got any problem with your eyes, every year you should have a detailed eye exam with your ophthalmologist, that they should dilate your pupils, they should have look at your retina and for the early detection of retinopathy. If the screening is positive for, then the patient has unexplained visual loss or without any retinopathy, the individual should be referred to ophthalmologist. Sometimes the patient came to the clinic has got unexplained visual problems. We cannot see with the simple ophthalmoscope. Then definitely these are the patients. They should be sent to the ophthalmologist for a proper slit line examination. That what's the problem. If the signs of retinopathy are present, then yes, the exam should be repeated annually, or its frequency should be suggested by the ophthalmologist. So if the ophthalmologist thinks that this patient should be seen every 6 monthly, you should go to your ophthalmologist every 6 monthly as his suggestion. Now, aspirin. Someone who has got retinopathy, then the aspirin can safely be prescribed in patient retinopathy, as it does not increase the chance of a retinal hemorrhage unless there is some other contraindication. So someone has got the retinopathy, so these patients should not hold actually their aspirin unless they are being advised due to some other reasons. Then another important thing for which we always consider to look is actually the nephropathy. That's the involvement of the kidney. Now, all patients with type 2 diabetes should be annually screened for urine for microalbumin or microalbuminuria annually. Advise that the serum creatinine should be measured every 6 monthly to calculate the EGFR, and some of the good labs will give you the calculated EGFR in their reports nowadays. The uncontrolled diabetes or hypertension, fever, infection, recent exercise, congestive cardiac failure may result in proteinuria without the kidney disease. So, looking at the proteinuria, but we must consider the other factors that can result into the proteinuria before labeling that patient, that this patient has got the nephropathy. So, how will you see? We usually ask that there should be two readings that should be 3 months apart before making a diagnosis of nephropathy, and we must exclude what I have read already, these things should be excluded before keeping a diagnosis of nephropathy with that patient. Diabetic kidney disease or diabetic nephropathy is identified when EGFR is less than 60 or albumin urea is more than 30 milligrams, 30 milligram in these patients. So someone who has got persistent macroalbumin urea, and the EGFR is declining, definitely these are the patient who has got the diabetic kidney disease. Now, if someone has got the persistent albuminuria, now these are the patients that needs the treatment. And what is the treatment? The treatment of choice for these patients is actually the SC inhibitor or angiotensin receptor blocker if these patients are not tolerating to the ARB, even in the normotensive patients after taking the baseline serum creatinine and potassium, as already mentioned by Professor Najum Islam, that you will check actually the potassium and the serum creatinine after 10 days, and then after 6 weeks, that looking at the is there any abnormal rise in the creatinine or potassium in these patients. For patients with the diabetes and chronic kidney disease, the use of sodium glucose transport inhibitors, that's again something which is nowadays is very positive results. GLP like peptide receptor agonist, and these two shown to reduce the chronic kidney disease progression in cardiovascular death are both. So someone who has got the chronic kidney disease, apart from the use of the S inhibitors or ARBs for the management of the diabetes, these patients should be on the SGLT2 inhibitors, or these patients should be on the GLP-1 receptor agonist that has got the protective role on the kidney function. In non-pregnant women with diabetes, hypertension, the antihypertensive S inhibitor or ARBs and combination, these S inhibitors or ARBs should not be combined, because the combination of S inhibitors and ARBs increase the incidence of hyperkalemia, and that's something which is not recommended from our side, that's the Pakistan Endocrine Society. In selected high-risk patients, serum creatinine and potassium be checked after 10 days and 6 weeks, as already mentioned, when the newly prescribed ACE inhibitor or ARBs. And it is common to have acute rise in serum creatinine of up to 30%, as said, within 2 to 5 days of initiation, and usually it remains same or reverted back to the normal creatinine level. So we must have a look at the creatinine level at the day 10 and after the 6 weeks. These drugs can safely be continued in patients if the creatinine is subsequently stabilizes at the higher level. And definitely it's not only the looking at the kidney function, but the control of the blood glucose level is actually the cornerstone of the management. So a good metabolic control is essential to delay the progression of nephropathy, and the dietary protein restriction should be restricted to 0.8 milligram per kg per day if its macroalbuminuria is present in these patients. Then another important thing for which we always say look into these patients is the neuropathy. All patients who with diabetes, they require the assessment of peripheral neuropathy on presentation, and the frequency of follow-up assessment depends on the presence of neuropathy or loss of protective sense. For every visit, at least we recommend that the patient's feet must be examined and seen, and if he has got complaining of neuropathy, then usually it's presenting complaint usually is the pain and the burning sensation, and about 50% of these patients may don't have got any of these symptoms and may be asymptomatic. Identifying these patients that they have got neuropathy is actually we prevent these feet from ulcers or from these ulcers when these patients haven't got any sensation and they may have got the ulcers without any pain. 10-gram monofilament, we recommend the 10-gram monofilament should be used, and the tuning fork should be used for the vibration and temperature sense to identify if the foot has the risk. What we use for these patients, usually the duloxetine, gabapentin, or pregabalins should be used in these patients, but there are certain other drugs we use with caution, but because they have got their own side effects, like amitriptyline or nortriptyline, they are also used in if they are not controlled on the previous drugs. But someone who has got the neuropathy, we must evaluate this patient for the secondary cause of neuropathy, because in patients presenting with atypical or painful neuropathy, other causes they must be excluded. And what are the other cause of neuropathy? Yes, these are actually the vitamin B12 deficiency, renal diseases, vasculitis, thyroid disease, vitamin D deficiency, neurotoxic medications, chronic inflammatory demyelination neuropathy. So, before going for labeling that patient that this is typically due to the diabetes, the other causes must be excluded in these patients, and they may help out in the treatment also for the neuropathy. The history regarding symptoms of autonomic neuropathy should be taken from the patients, and if the appropriate, for example, the tachycardia, if the cardiovascular system is involved, the gastrointestinal tract, for example, the gastroparesis, genitourinary system like erectile dysfunction. So these are some of the other factors that may present in different way for the autonomic neuropathy in these patients also. Screening for the coronary artery disease, as Professor Najum Islam has already mentioned, for the control of the lipids and control of the blood pressure. Screening for the coronary artery disease when the patient has atypical or atypical symptoms. Sometimes we know that these diabetic patients don't have got typical chest pain, especially the diabetic. So someone who has got the typical or atypical symptoms like the chest pain, shortness of the breath, orthopnea, proximal nocturnal dyspnea, and these patients, they should be evaluated for the cardiovascular symptoms. And we always recommend that all diabetic patients, they should be annually checked for hypertension, the dyslipidemia, smoking, obesity, and family history of cardiovascular or premature cardiovascular death. So these screenings are also important as a part of management of the diabetes. And special attention should be paid to the patient who are presenting with the microvascular complication, someone who has got retinopathy or microalbuminuria, someone they should have got a silent microvascular complications as well. So someone who has got the retinopathy and microalbuminuria, they should be looked for the other macrovascular complications in these patients. For aspirin, we have already said that someone who is more than 50 years of age that's got the other comorbid, they should be the looked for, taken history for the aspirin, the S inhibitor ARBs for hypertensive patients with the nephropathy. Then another drug which should be the used very cautiously in the elderly people, the TCDs, because they can exacerbate the congestive heart failure, edema, especially in the elderly patient who may have got underlying or asymptomatic ischemic heart disease. So TCDs should be used very cautiously in the elderly patients. Peripheral arterial disease, again something which is not uncommon in the diabetics, especially after a long history of diabetes. So the peripheral arterial disease should be evaluated. A simple method is that we always palpate the foot pulses and measure the systolic blood pressure to calculate the ankle brachial index. If symptoms of peripheral arterial disease are present, then definitely we recommend that the patient should be referred to the secondary or tertiary care center where more advanced tests are available, and this patient should be evaluated more for the peripheral arterial disease. Now, all diabetics with a non-healing ulcer or antebrachial index, they should be referred, as I said earlier, for more evaluation of the peripheral arterial disease by color Doppler, ultrasound, CT angiography, MR angiography, or standard X-ray angiography. So there are different tools that should be evaluated. Like for example, what we are doing for the heart is actually the angiography. So there is peripheral angiography are also available in these patients, and there is stenting nowadays. This is also available in tertiary care centers when they put a stent in the peripheral arterial disease and open, and that actually prevent the limb from the necrosis or further damage in these patients. Now, all patients with diabetes and ischemic foot ulcers should have aggressive cardiovascular risk management. Smoking cessation is on the top. Treatment of hypertension and the blood pressure should be on a goal. The glycemic control is very important, and prescription of the statin as well, and a low dose aspirin, all clopidogrel, they should all be part of the management. Someone who has got the diabetic or ischemic foot ulcer. So it's not only that we look into the ischemic foot ulcer, but we look as a whole, and all these modalities should be part of the treatment of that foot ulcer. Now, consider the reevaluating the diabetes regimen in the individuals, and again, the SGLT2 inhibitors used should be assessed, and that have got the potential of complication of amputation when used in patient with the peripheral arterial disease. Now, someone who has got the peripheral vascular disease, the SGLT2 inhibitors should be used cautiously, because in some of the studies, in one of the studies they have shown that makes exacerbate actually the peripheral vascular disease. But usually what we have seen in our clinical practice, this is not very common, but a point of caution should be there that someone who has got a peripheral vascular disease, if you are using the SGLT2 inhibitor, that should be repeatedly evaluated, that it should, the peripheral vascular disease is not worsening. So a word of caution should be there when you are using in these patients. Feet should be examined at every visit, and in the presence of peripheral neuropathy, peripheral artery disease, the healed ulcers, foot deformity, pre-ulcerative signs, improper hygiene of the food, and that is the reason that we always recommend that actually someone is always encouraged, always given the teaching for foot care also, because we always say that the care of foot should be more than care of your face, because in a diabetic, foot is more prone for all these complications, and that sometimes may be very dangerous and can lead to the gangrene and amputation in these patients. The risk category should be assigned for further prevention. Examination is always important in these patients, and as I said earlier, the monofilament is important for looking at the peripheral vascular disease, and this is something which we should all do in these patients. Tuning fork with the 128 hertz tuning fork for the vibration sense, and the tendon reflexes should be examined in these patients when we are evaluating these patients. There is a role of vascular surgeon, definitely. There's someone who has got the intermittent claudication, that definitely these patients should be referred to the vascular surgeon or to the centers where there is the facilities for peripheral arterial angiogram is there, and the person with the diabetic foot ulcer should be referred to a diabetic foot clinic with the treatment with a multidisciplinary specialized team that will reduce actually the risk of amputation at the time of functional recovery. So someone who has got a small injury or ulcer should be taken seriously and should be referred to a multidisciplinary team where there is a proper management of the foot ulcers, that it should not increase in size, that will involve whole of the foot or whole of the leg, and that leads to the complication. So the foot ulcer in a diabetic patient should be taken very seriously. Thank you for your kind attention, and now we come to back to the Ali.
Thank you very much, Professor Dr. Saeed Maher. Has been a fantastic talk on diabetes and cardio we'll be extending the question answer session as we go forward. So let me ask the first question that we have got from Professor Najmul Islam. Professor Islam, the general practitioner has asked that you have said that when we start AC inhibitors or ARBs, the creatinine levels can go up by 30%. Now, the doctor has asked that the experts these days suggest we can use ARBs and ACE inhibitors even in advanced chronic kidney disease. Always confused as to what GFR we can actually use ACE inhibitors and ARBs. Can you tell us at what kidney function we can safely start, knowing that we need to check the creatinine and potassium? What can be the kidney level, the creatinine level, or the GFR where we can actually start in ACE inhibitors and ARBs?
We have to be very careful or cautious really in starting uh, ACE inhibitors and ARBs in patients with advanced kidney disease because of the risk of hyperkalemia. That is something that, and that is the reason why lots of patients with advanced end-stage renal disease may not be on ACE inhibitors and ARBs. So that is very careful. And the concern is the hyperkalemia, because as such these patients are having hyperkalemia. So adding a drug which increases the risk of hyperkalemia causes further problems. So that is the group. But in terms of CKD, mild to moderate CKD, you can safely start without much of an issue, but you need to monitor the potassium and the creatinine after starting it to make sure that they are within the limits of the potassium, and the rise in creatinine is to an acceptable level there, which is up to the maximum 30%. But if it is much more than that, then you better stop the ACE inhibitors in ARB, because that maybe the patient may be having underlying kidney artery stenosis, which may cause worsening of the kidney.
Okay, thank you very much, Professor Islam. Professor Saeed, there's a question for you. You have advocated aspirin in primary prevention. Now, the question is that we have seen endocrinologists started aspirin 75 milligrams on alternate days or maybe sometimes twice a week. What would you suggest in somebody who is between 50 and 60 years of age? What dose of aspirin should we be starting safely in these patients for primary prevention? And also, please tell us what would be your take on starting aspirin for primary prevention for overweight.
Uh, uh, Ali, as I very clearly mentioned in my talk also, and this is also the recommendation of Pakistan Endocrine Society, that someone over the age of 50 with the other comorbids like a family history of cardiovascular disease, hypertension, dyslipidemia, these are the patients in which we say that the aspirin of 75 milligram per day should be used. There is no recommendation of aspirin on alternate day or twice weekly. This is very clearly mentioned in the guidelines that over the age of 50 with the comorbids, which we have clearly mentioned in our presentation, these patients should be, if there is no contraindication, someone who has got the bleeding tendency, then one should be very careful about it. But someone who has got age more than 50 with the other comorbids, the dose should be 75 milligrams.
Thank you very much, Professor Said. Professor Islam, there's a question for you. What should we do? Some guidelines, they suggest statins to be used to maintain a certain level of LDL cholesterol, yet other guidelines say we should use moderate and high dose statins. In our patient, if the LDL cholesterol is controlled on moderate dose statin, can we go down to low dose statin in somebody who is at high risk of cardiovascular disease?
Somebody whose lipids are controlled on a moderate dose statins, moderate intensity statins, that should be continued rather than decreasing it to lower level, lower statins. That is not my take of because if you start statins should be moderate dose statins. But if the patient has cardiovascular disease, it should be high dose.
Okay, thank you, sir. Professor Saeed, there is another question for you. Somebody who has retinal hemorrhage history, what would be your take on giving aspirin in primary prevention to these high risk for cardiovascular disease, diabetic, patients?
Yeah, Ali, this is again, I have mentioned in my presentation that the retinopathy and the stage until and unless this is a gross one and the ophthalmologist is very concerned about it, usually we do not hold the aspirin in these patients. So usually with the small important blood hemorrhages, we usually not. This is again the recommendation what we have discussed today. We have mentioned in my talk that this should not be stopped in these patients.
Okay, thank you very much, Professor Saeed. Dr. Islam, there's another question for you. I mean, the doctor asks that which statin we should start. There are so many statins available these days. What should be? Is there any criteria to pick up certain statin as a choice over other statin? And if there is any difference, would you please highlight this?
देखिए मॉडरेट इंटेंसिटी स्टैटिस में रोजुवेस्टेटिन है, एटोरवेस्टेटिन है, सिम्वास्टेटिन है, एरोवेस्टेटिन है, ये सारे लिस्टेड हैं फॉर मॉडरेट इंटेंसिटी स्टैटिन। और हाई इंटेंसिटी स्टैटिस के अंदर वही हैं एटोरवेस्टेटिन और रोजुवेस्टेटिन एट हायर डोज। Double atorvastatin 40 to 80 milligrams is the high intensity statin, and 20 to 40 milligrams of rosuvastatin is the high intensity statin. Now we're coming to moderate intensity statins. This for atorvastatin it is 10 to 20, and rosuvastatin 5 to 10 days they are taken as moderate intensity statins. By and large, the two common statins that are to be used as atorvastatin.
Okay, thank you very much, sir. Professor Saeed, there is another question for you. These days, we know that SGLT2 inhibitors are a new class of drug in diabetes, especially with cardiovascular disease. And we know that in peripheral vascular disease, as you have said, SGLT2 inhibitors should be used with caution. Now, somebody who has cardiovascular disease, I mean, there is a much chance she having vascular disease as well. So what would we do? I mean, when should we use SGLT2 inhibitors in these patients? Because we know that somebody having cardiovascular disease might have a big chance of having peripheral vascular disease. This has been asked. Please, if you could elaborate on this.
Yeah, someone who has got the established cardiovascular disease, I think these patients should always be on a SGLT2 inhibitor. But definitely, you have to look on every visit for any worsening symptom or any worsening of the peripheral pulses when these patients come to you. And if these patient has got the symptoms or signs of worsening of the peripheral vascular disease, then you should have a word of caution. But these actually SGLT2 inhibitors has got very beneficial effects on the cardiovascular system. So they should be part of anybody who has got established cardiovascular disease nowadays.
Thank you very much, Professor Saeed. Another question to you, Professor Islam. Somebody who is diabetic, uncontrolled with a triglyceride level of 400 to 450, would you still treat this patient with fenofibrate or gemfibrozil, or should we just control diabetes and expect this triglyceride levels to go down?
देखिए
Somebody with uncontrolled diabetes and a triglyceride level of 400.
Somebody who has triglyceride levels of 400 or 450, and you need to control the diabetes and expect the triglyceride levels to go down. But when it comes to starting a lipid-lowering drug, statins are preferred in this group of patients, and only if the triglyceride level is more than 500, we should be going directly to fibrosis.
Okay. Professor Saeed, there is another question that has been asked. You have recommended that eye examination should be done by diabetes expert in his clinic. Now, the doctor says that you know that there's already a lot of burden of diabetes patients on general practitioners. Would you still recommend the fundoscopy to be done by the general practitioner in his clinic? Or if doctor writes at his clinic, would you recommend fundoscopy by the doctor, diabetes doctor in clinic, or a visit to eye specialist once a year?
Now, if someone who has got the training that he can pick up the retinopathy in his clinic, that he has got the facilities for the dilated eye exam in the clinic, then the doctor should do himself or herself the initial eye examination. But if someone is not able to do and hasn't got any training for that, the ophthalmoscopy, then I will recommend that these patients should be sent to a proper ophthalmologist annually, and these patients should be said that there should be an annual eye exam. Sometime what we do, that the patient think that if we have got the problem, then we go to the ophthalmologist. But these patients should be told right in the beginning that, look, if you don't have got any symptom, you don't have got any problem, you have to go to the ophthalmologist every year. So this is something which we always can assess ourselves. If we can do in the clinic, yes, initially good. If you see there is something hemorrhages or something like that, you can pick up on the ophthalmologist, refer to these patients. You can do it yourself, that's fine. You cannot do it, and these patients should be going to an ophthalmologist every year.
Thank you very much, Professor Saeed. Professor Najum, there's an interesting question for you. I mean, hearing the use of statins and on different platforms, the doctor asked that it seems like statins should be given to all or most diabetic people. Can you kindly specify for our simplicity which is the subset of diabetes patients who should not be receiving statins? Because the doctor says that in his perception, I mean, most of the diabetes patients should be on statins. So which is the subset of patients who should not be on statins but are diabetic?
For example, the type 1 diabetics, young person who's in his teens and early 20s, and he should not be on a statin unless there is a risk factor, a very high risk factor for a cardiovascular disease. That patient should not be on a statin. Straightforward, easily. But if somebody is in his 30s and 40s and has a risk factor, then we need to consider above 40, almost every diabetic should be on a statin.
Okay, thank you very much, Professor Islam. We also have some...
Just another clarification. Pregnant ladies should not be on a statin, irrespective of whether they are diabetic or not. There should not be a statin. So you have a diabetic patient, and if somebody is planning pregnancy, may it be type 1 or type 2, should not be put on a statin.
Thank you very much, sir. Because we are in the second session, day 2. Some of the questions are all Saeed, there is a question that we have seen that liraglutide is being used for weight reduction in non-diabetic patients. What is your say on this, please?
Okay, now the liraglutide is officially been allowed for the use in weight reduction with the higher dose, with the 3 milligram, and the drug is coming with the name of Saxenda. It's not, although it's not available in Pakistan, but this has been licensed for use in non-diabetics also, for weight reduction also. So this is being used in different parts of the world, but Saxenda is still not available in Pakistan. So liraglutide for weight reduction also.
Thank you very much, Dr. Saeed. Professor Islam, the very important question. Somebody with chronic kidney disease, a creatinine level of around 4 and 5, what will be the best treatment for high blood pressure at this creatinine level?
I mean, at this creatinine level, and particularly if the potassium is at the higher limit of normal, I would be avoiding C inhibitors and ARB. But there are calcium channel blockers that can be used. Hydrolysine can be used. Alpha blockers can be used. Beta blockers can be used. There are many of them. Can be used safely.
Okay, so there's another question, Professor Saeed. Somebody who is diabetic with peripheral vascular disease, chronic kidney disease, heart failure, and low ejection fraction. Now, in these patients, would you still recommend antihypertensive therapy together with SGLT2 inhibitors? I mean, is there a chance of the blood pressure going low? I think the doctor wants to ask, what about SGLT2 being added to antihypertensive treatment? Somebody who has low ejection fraction, what is the chance of low blood pressure and what is the chance of compromised blood flow to the extremities?
Now, someone who has got the heart failure, as is mentioned already, and for example, if the patient is on the antihypertensive and diuretics, we usually recommend that when you add the SGLT2 inhibitor, usually you have to reduce the dose of diuretics either by 50% or for a couple of days you can just hold the diuretic and look at the blood pressure, because this is a clear cut mention in many of the trials that the SGLT2 inhibitors that actually prevent the readmission in the heart failure patient, and they are beneficial for the heart failure patient. So, word of caution that the diuretic should be reduced by about 50%, and then we have to monitor these patients when we add actually SGLT2 inhibitors.
Thank you very much, Professor Saeed. Dr. Najum, there is a question. If a patient is diabetic, hypertensive, and also has autonomic neuropathy, and he's having postural drops, would you still start this patient on ARB or ACE inhibitors as antihypertensive treatment, and also to prevent chronic kidney disease and heart disease?
That is a difficult question. It all depends what is the main issue. If the patient is very much symptomatic from postural hypertension, then you have to be careful in treating the systolic blood pressure and may not try to bring it at the target that I have talked about. As when the patient stands, there is a lot of blood pressure, and that is symptomatic. That is a very tricky thing, has to be visualized. But in a patient who does have a lot of blood pressure but not very symptomatic, then you should be using blood pressure so that the blood pressure precipitation is less than 140.
Okay, thank you very much, sir. We've got lots and lots of questions coming in. We'll try and take 2 or 3 more questions. Dr. Saeed, SGLT2 inhibitors, what about using them in chronic liver disease, especially in compensated and decompensated chronic liver disease patients? Can we use SGLT2 inhibitors in these patients or not?
Usually, I will say not in the decompensated patients, because there is a frequency of urination, and the patient may worsen in these cases. But yes, in compensated liver disease, yes, we can use with the caution, and we always monitor the things cautiously. So definitely you can use it, but with the word of caution in these patients, and looking at actually the blood pressure levels and the fluid, how much they don't want to become. We don't want to keep these patients hypotensive. This is that we use very cautiously in compensated chronic liver disease patients, but not in decompensated.
Thank you very much, Professor Saeed. And just the last question. Thank you very much, Professor Saeed. Just last question from Professor Dr. Najmul Islam. So what do the guidelines suggest? Can we give ACE inhibitors or ARBs in patients with diabetes mellitus who do not have hypertension, but they have
Ali, I could not hear your questions completely because of the technical problems of your. Would you mind repeating it, please?
Yes, sir, sure. I mean, the question is that what does the guideline suggest? Can we use ARB inhibitors or ACE inhibitors, ARBs or ACE inhibitors in patients with diabetes who do not have hypertension, but they have albuminuria?
Yes, yeah, that is what we should be doing really. Those who have blood pressures are normal and they have got microalbuminuria or macroalbuminuria, we should be using ACE inhibitors or ARBs, and because that has shown in trials to delay progression of the disease. So that is fine. That is acceptable. That is by us as well as by the nephrologists.
Thank you very much, Professor Islam. Professor Saeed, let's take one more question for you. Very burning question, and I have to take it actually. What is the recommendation for SGLT2 inhibitors in Mahi Ramadan?
Yes, this is something which is, yes, very interesting. Ramadan is coming, so yes, you can use actually the SGLT2 inhibitors in Ramadan, but usually we recommend the timing should be changed. We usually use SGLT2 inhibitors in the morning time. So in a Ramadan, we always ask or suggest to the patient to please maybe have the aftar time when the patient can have the fluids and can use the washroom if he has got more frequency, then they can be used, but the timing should be changed and they should be taken at the aftar time instead of sari time.
So continue till Maghrib. We have got so many questions lined up. Thank you very much to all our participants from across Pakistan. Thank you very much, Professor Dr. Najmul Islam, Professor Dr. Saeed Maher. You have been fantastic endocrinologists, and thank you so much for taking out time from your busy schedules. Pakistan Endocrine Society is thankful to you, both of you. Thank you very much, Gets Pharma, for helping Pakistan Endocrine Society disseminate these guidelines, which have been exclusively prepared by Pakistan Endocrine Society. And with this, once again, thank you very much to all of you, wonderful speakers in Gets Pharma. Let's have a lovely weekend together. Thank you very much. Allah Hafiz.
Thank you, Ali.
Uh,
Hafiz.
uh,
Hafiz.
Allah Hafiz. Allah Hafiz.